Imagine if you could take a deluxe BuzzFeed quiz. Boo hiss, I know, but now you know what I'm talking about. And this deluxe quiz could tell you if you were experiencing just normal sadness or depression, anxiety or anxiety, if you were seeing things out of the corner of your eye because you're tired, or if this was indicative of hallucinations and something you should be worried about. Now, instead of an online quiz, imagine that you are a mental health practitioner who's seeing patients, and you need to help them figure out if it's just sadness or depression, anxiety or anxiety, being tired, or maybe early stages of schizophrenia. How do you do this? There are a lot of tools that mental health practitioners have at their disposal to help them make these decisions. They don't have to just sort of wing it and use their gut instinct, although some of them prefer to do that. There's tests, there's interviews, and a lot of that falls under psychometrics, which is not what we're here to talk about today. Today, we are going to talk about sort of the gold standard right now for doing this sort of thing, which is the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM. Welcome back. Today we are continuing on sort of where we left off with the psychological disorders video. As a quick refresher, in that video we talked about the mostly Western history of how psychological disorders have been viewed and treated, and ended on the biopsychosocial approach, which tries to incorporate biology, so like genes and other stuff sort of out of your control, psychological elements, so mental stuff, past history, experiences, things of that nature, and social or cultural. These are the larger environment, the cultural environment factors that can play into things. We also talked about how psychological disorders are defined, and talked about 3 rough criteria that you can use to think of for classifying behavior as ordered or disordered. 1 is if it is deviant from the cultural norms, so that is taking what's appropriate behaviors in a given culture into account. 2nd, if it's distressful for the person or people around them. And finally, if it is dysfunctional. So dysfunctional behavior is getting in the way of leading a normal, productive life. Finally, we talked about the impact of labeling behaviors or people as disordered. And we talked about Rosenhan's 1973 experiment on being sane in insane places. And I'll go through that a little bit in this video as well, so don't worry about if you don't remember what that was exactly. Also, as a reminder, this topic, DSM and eventually psychiatry, was a Patreon poll winner. So if you would like to have input on future content that appears on this channel and things I talk about, see what's happening behind the scenes, have access to the monthly live stream that are now happening, check out my Patreon. Link in description box below, as well as links to my Twitter, Discord, Instagram that I post to very occasionally, all of that description box. All right, now with the obligatory YouTube link drop, let's get on to the DSM. I should make it 100% crystal clear at the outset here that while I'm talking about psychological disorders, the DSM, all of this stuff, I myself am not a clinical or counseling psychologist. I'm a cognitive psychologist, and I'll put a link below for a video talking about what's the difference. Basically, I can talk about this stuff as an educator. I taught for many years. You talk about this stuff. But I have no training in how to do this stuff. I don't have a license to do it. Like, it's a hobby? Is that what we want to call it? As you'll see in the psychiatry video that will come eventually, this is a topic area of personal interest to me and also just intellectually interesting. But again, I have 0 training and 0 authority to diagnose people, to treat people, to any of that. So just keep that in mind as we go forward. Quick outline of this video's flow. First, we will talk about the current state of the DSM, how it's used, what it looks like in practice. Then we will go through the DSM's history and talk about a couple disorders over the course of history to kind of give you a sense for how things have changed over time. And we'll wrap up with some critiques of the DSM, as well as talk about some alternatives that are either in the works or could potentially replace it today. All right, let's go. The Diagnostic and Statistical Manual of Mental Disorders is an authoritative volume that defines and classifies mental disorders in order to improve diagnoses and treatment. We'll go through its history and revisions in a few, but just know for now that it's on its 5th edition. The DSM has a couple different uses presently. One, it's used by practitioners to help them diagnose people with the appropriate disorders that they are experiencing. 2, it's then used to help communicate those disorders to insurance or other billing entities that need to know that information. 3rd, it's used experimentally. And in experiments, it's used to help screen or classify people based on their disorders. So let's say you're doing an experiment that involves something with depression. And so you put out an announcement, I need people with depression for this experiment. They come in and you do a screening. And in the screening, you run them through basically the checklist of if they meet the criteria for depression under the DSM or not. If they do, you include them in the experiment. If they're not quite there, you thank them for showing up or for their time, but they don't meet the criteria and send them on their way. And then when you write up this experiment, you can say that you use the DSM-V diagnostic criteria for depression for inclusion criteria for this experiment. The 5th edition of the DSM is broken into 3 sections. The first section includes basically a huge honkin' changelog between the last edition, which is the 4th text revision, and the current edition 5. And they overhauled a bunch of things, so there's a lot to be said there. The section also compares the DSM-V against one other system that's used a lot in the health industry, the ICD-10, and we'll talk about that more later, but just know that they tend to be written kind of in close contact with each other. The last big part of this section is a discussion about maybe this form of categorization for the mental disorders isn't the best way to go about things, but we don't really have an alternative available yet, so let's just keep doing this for now. Section 2 is the meat of the manual. This is where the disorders are. This is where the organization of the disorders happens, the diagnostic criteria, just everything you want to know about these disorders that's going to be in the DSM is here. Section 3 is focusing on signal boosting, this idea that we need to really change the way that we think about disorders and how we classify them and how they fit together, and encouraging the scientific community to focus research efforts there. Before diving into the 22 categories of psychological disorders in the DSM-V, let's take a second to talk about comorbidity. Comorbidity sounds a lot worse than it is. What it basically means is a person has more than one psychological disorder at a time. And this is usually talked about in the context of a couple disorders showing up together kind of consistently across people. As an example, depression tends to be comorbid with some form of anxiety disorder like social anxiety, generalized anxiety, maybe both, phobias, And so we say that depression is comorbid with anxiety. That just means that if you have depression, you have an increased likelihood of also having something like anxiety. This also means that you aren't restricted to just one disorder label or category by the mental health practitioner. They can use the appropriate number of descriptors for what's going on with you. As an example, I've got bipolar disorder, as well as generalized anxiety disorder and OCD. These are the best fit descriptors of what's going on with me. Alrighty, so the current categories of psychological disorders are neurodevelopmental disorders, which start earlier in life and impair normal functioning and development. Examples here are things like the autism spectrum disorders, ADHD, other things that tend to develop early in life. The schizophrenia spectrum and other psychotic disorders. This group is characterized by disruptions in perception, thought, language, emotion, and behavior. Schizophrenia fits here, as does schizoaffective disorder. Bipolar and related disorders sit between the schizophrenia stuff and the depressive disorders because it can sort of be like a Venn diagram between the two. In addition to low mood problems, as seen in depression, mania, when extreme enough, can become quote-unquote psychotic. The depressive disorders are characterized by low mood in some manner. Major depressive disorder is what we're usually talking about here when we say depression, but there's also variants of it, such as seasonal affective disorder, where the depression tends to hit in the fall or winter, at least in the northern hemisphere, opposite in the southern hemisphere. There's also disruptive mood dysregulation disorder, or DMDD for short, which is basically depression that's developed in a child. The anxiety disorders are anxiety disorders. Examples here are things like generalized anxiety disorder, social anxiety disorder, or specific phobias. Neighboring the anxiety disorders are the obsessive-compulsive or related disorders. This is basically the obsessive thoughts and/or compulsive actions associated with things like OCD. Trauma and stress-related disorders develop in response to a traumatic event. Post-traumatic stress disorder, PTSD, is the exemplar here. Dissociative disorders are characterized by disruptions or discontinuity in a person's identity, conscious experience, or memory. If a person experiences bodily symptoms in the absence of a physical cause, it would fit into the somatic symptoms and related disorders. Feeding and eating disorders are problems with eating or feeding and are strongly tied to advertiser-unfriendly terms. Elimination disorders involve problems with inappropriate urination or defecation. The most straightforward example of this would be wetting the bed. If a person has trouble in some way with sleep, they would have a sleep-wake disorder. Examples here include insomnia or narcolepsy. Sexual dysfunctions occur when there are issues with unsatisfactory sexual activity, like finishing too early or having problems getting aroused. Gender dysphoria is, quote, characterized by an incongruence between a person's experienced or expressed gender and assigned gender. Disruptive impulse control and conduct disorders are disorders with a common issue in having trouble controlling unwanted behaviors, such as nicking stuff and kleptomania, or an almost inbuilt inability to follow directions or empathize with others in conduct disorder. When a person has become addicted to something, be it a substance or behavior like gambling, their addiction and subsequent dysfunctional behaviors would fall into the substance-related and addictive disorders category. Neurocognitive disorders include disruptions to normal thought as a result of something happening to the brain, such as Alzheimer's disease or from a traumatic brain injury. We've previously touched on the personality disorders, specifically in working our way towards narcissistic personality disorder. Briefly, the personality disorders encapsulate consistent behavior patterns, thoughts, and feelings that lead to significant life problems. The paraphilias are characterized by inappropriate sexual activity. Naming them would almost certainly raise the ire of dear algae, but one ends in philia and involves adults and kids in not good situations. Other mental disorders. This is sort of a catch-all for disordered behavior that's causing distress, but doesn't really fit into any of the existing categories. Medication-induced movement disorders and other adverse effects of medication. These can be random muscle twitches or tremors that develop because of taking a medication, or just the other side effects that sometimes come with some of the medications that are available. As I talked about in my trigeminal neuralgia rant, I have been unlucky enough to experience some of these. So I've learned how to move the muscle that makes your ears wiggle, because one medicine I was on was causing that muscle to twitch a lot. I've also experienced a finger muscle twitch where it would just sort of just move on its own, do its own thing, and that was eventually spreading up my arm, so that medication was stopped. I've also experienced just a general muscle tremor. Sometimes, it's just a slight muscle shake, especially trying to do fine motor movements, but on one occasion with one particularly nasty drug, it was like a violent shaking, and that was a solid pass. These suck. And it also sucks because if you experience that and you keep taking the medication, it can become permanent. You stop the medication, but you're left with this muscle spasm or tremor. Finally, other conditions that may be worth the focus of clinical attention. So this is a huge umbrella term for basically anything that you might want to talk to a mental health professional about. Relationship problems, abuse, neglect, just stuff that you would need to talk to somebody about. Okay, so those are the categories of psychological disorders in the DSM. How do you get from that to arriving at a diagnosis for a person when they're seeking treatment? When you're first interacting with a mental health practitioner, be it a psychiatrist, psychologist, social worker, whatever, they are going to be getting as much data from you as they can. And there's many different ways for them to do this, and basically everybody sort of has their own approach. They can do this through an unstructured interview where they just ask questions, have a conversation with you, and try to fill in whatever blanks or check whatever boxes they think is going on with you. There's also structured interviews where it's more set, the order that things are talked about or how things are talked about. And overall, those tend to have better diagnostic validity and reliability, but topic for another day. There's also psychometric tests that can be given, like the EAT test, I think, for eating disorders, where I forget what it's like eating apperception test or something. It's the EAT. And you take this test, you get a score, and that's indicative of how likely you are to have some problems with food or if it's something that warrants further investigation and treatment. And here's some advice that I was given when I took abnormal psych so many years ago. If you are seeking help for some sort of psychological problem, and in the first communication with this new person that you're seeing, it doesn't come up if you've had a physical or blood work or anything recently, find a new practitioner. They're not doing their due diligence in ruling out problems. And it's important when you're setting up treatment, especially for something that's new, that physiological causes, bodily causes be ruled out. So an example for this is depression. If you're suddenly feeling depressed, you've got the low mood, low get up and go, all of that, it's possible there's something wrong with your thyroid. And it's really important that your thyroid be tested first, because if that is what's going on, we can treat the thyroid and improve the depressive symptoms. But if that thyroid isn't tested, we don't know if that's the cause. And you could be taking antidepressants and maybe they help, but we're missing this important piece of the puzzle here that it's actually the thyroid, and there's other things that go wrong with the thyroid, and we should really be addressing that instead of just sort of treating the symptoms. Okay, so your practitioner has made sure that you've got a clean bill of health. They've gathered all the data that they think they need. Now what? Well, now they are going to take that data and try to make sense of it, probably using the DSM. Let's go through an example of what that intake process can look like to give you a sense of what goes on. So this is not based on training I've received in doing this sort of interview. This is actually based more on my experience of the receiving end, having been through several intake interviews in my life, and also integrating that with the current diagnostic criteria in the DSM-V. If this stuff resonates with you, if this sounds like answers you could be giving, get thee to a doctor, okay? Okay. A person goes to see a mental health practitioner because they've been feeling kind of down recently and it's been impacting their life. Let's say they've been referred to a psychiatrist from their general practice doctor, and the blood work was done by the GP, so that information would be available for the psychiatrist at this appointment. So this sounds like it could be depression. If you go on Dr. Google, that's probably what you would see, but what type of depression? How severe? What's the best treatment option? All of this stuff is things that'll hopefully come out of this appointment with the psychiatrist. Also, I should mention that you probably won't just be read the diagnostic criteria in this intake interview. It'll be done a little more subtly and gracefully than that. But I will go through sort of the explicit diagnostic criteria and this hypothetical person's responses to those criteria questions. The DSM-V's diagnostic criteria for major depressive disorder includes that the person must have experienced at least 5 of the listed symptoms for at least 2 weeks, and one of the symptoms must have been depressed mood or loss of interest or pleasure. Was the person depressed most of the day, nearly every day for the past 2 weeks? And they say, yeah, they were. Did the person experience markedly diminished interest or pleasure in things that they've previously enjoyed doing? And the person says, yeah, they have. Has there been a significant change in their weight or their appetite, either eating less, eating more, gaining weight, losing weight? And the person says, not that they've noticed. Has the person been sleeping too little or too much nearly every day? And yep, this is one that they feel fits them. Has the person been feeling either physically restless or that it's hard to move? And this is one again that they don't think they've really noticed. Has the person experienced fatigue or loss of energy nearly every day? Yes, absolutely, this is something the person's experienced. Has the person experienced feelings of worthlessness or excessive guilt? And they're not sure, so leave that as maybe. And depending on the person doing the interview, that maybe might be fine to let hang, or the maybe might need to be clarified into a yes or a no. Has the person experienced a reduced ability to think or concentrate? And this is again something that the person says, yep. Has the person had recurrent thoughts of death or ending their life, with or without a plan? And this is a solid no from the person. The person is asked when their last physical was, or if there was blood work done recently, was their thyroid checked. And they say, yeah, their GP had that blood work done and it should be in their file. The psychiatrist pulls up their file and yep, okay, your thyroid looks to be perfectly healthy, so let's continue on. So at this point, the psychiatrist can probably be pretty certain that this person is experiencing depression. It's not their thyroid, and they met that 5 criteria for at least 2 weeks thing. So it's probably depression, but what's going on? What's causing it? We need more info. So the person is asked if they've recently experienced the loss or death of a loved one or somebody close to them. And nope, not that they know of. So then the psychiatrist asks, okay, is this the first time this has happened to you, or have you experienced these feelings and this experience before? And the person thinks about it for a little bit, and actually, now that you mention it, this tends to happen around Christmas. And the person didn't really think anything of it, but it's gotten to a point this year where it's disrupting their life. But it has happened previous Christmases. So this information is interesting for the psychiatrist. So they want to know more. So they ask, can you tell me a little bit, how many years has this happened? How does it tend to go? And the person says, okay, it's happened for at least the past handful of years, and it tends to hit maybe around Halloween, Thanksgiving for sure, and tends to go definitely through Christmas. The doctor asks for a little clarification, how long past Christmas? And the person can't really put a finger on the exact day when things get better, but it does tend to last a little bit into the new year. Just to make sure that they're not missing something, the psychiatrist asks if there's any super stressful events that happen around Christmas pretty regularly, like if they're a seasonal worker or something of that nature, and the person says nope, they've been steadily employed for the past however many years, and it's just they thought it was the stress of the season, but it's bad enough they're seeking help. So the psychiatrist probably has enough information at this point to be able to say that this person has major depressive disorder with a seasonal pattern, more commonly known as seasonal affective disorder. And so the psychiatrist lets the person know this and then says, we have a couple treatment options to try. Of course, we can try different antidepressants like Prozac or Wellbutrin or other things, but other things that prove effective for this are things like this special sun lamp that just helps replace the sun that you're missing in those darker months. And that can be enough for some people. So the person makes their choices for what they want to try and goes off, has follow-up appointments with the psychiatrist, and hopefully things improve. So again, this is an example based on my experience with intake interviews, a couple people I've known with seasonal affective disorder and what it was like for them, what worked for them. And again, if this sounds like you, talk to your doctor, please. All right, so examples over, there's a couple things I want to point out here. First, this hypothetical person didn't have all of the diagnostic criteria for depression. They had some of them, but not all of them. And this is actually pretty normal. People vary in how they present with the different disorders, and so part of that variability is incorporated into the diagnostic criteria. For most of these disorders, you don't have to have every single symptom in order to match the label or the category for that. Second, something I've heard quite frequently as a nail in the coffin of psychiatry or taken to be evidence that the psychological disorders aren't a thing is that these diagnostic criteria can include what are apparently opposites of each other. Eat too much, eat too little. Sleep too much, sleep too little. And this doesn't mean that the mental health practitioners don't know what the hell they're doing. It just means that people manifest their disorders differently. And the important thing here is that, let's say depression, results in a change in appetite or a change in sleeping behavior. Could be too much, could be too little, but there's a change. And we'll talk about this towards the end of the video, but what this might be indicating is that we're dealing with different varieties of depression or schizophrenia or whatever. So for some people, depression is an increased need for sleep and an increased need to eat food, and for others it is a decreased need for sleep and a decreased need for food. And this could be reflecting either different neurotransmitters doing things, different brain areas doing things, maybe probably having different genetic components playing into what's going on here. This leads us to the final point I want to talk about, which is it is the case that we currently do not have an easy test for the different disorders. You can't just have your blood drawn and get a test back that says negative for depression, positive for generalized anxiety disorder. We're not at that point yet. And just because we don't have a blood test or whatever for these different disorders, it doesn't mean that the disorders aren't real. We are getting to a point with genetic testing and identifying that stuff where we can kind of see the genetic predisposition for developing the different psychological disorders, but that doesn't tell the whole story. The easiest way to get the whole story is to talk to the person, see what they say, see what they're experiencing, and use that genetic information to kind of disambiguate situations where you're not sure if it's one disorder or another, when possible. There's also an increasing amount of data available about brain differences between the average happy, healthy, normal average brain and brains with the different disorders, either functional data where people are doing tasks or just anatomical data. There's some brain differences. And the thing we don't know yet is if the disorder causes these brain differences, if the brain differences cause the disorder, or if there's some other third mediating factor at play here. For example, with some schizophrenia studies, it could be possible that the brain region differences that we're seeing between the schizophrenics and the people without schizophrenia is a consequence of the medication that they've been on. We can't rule that out yet. Okay, so that's roughly where we are now with the DSM. Let's talk about where it's been. Before getting started, two things. First, just a general comment that the numbers I'm giving for the number of diagnoses included in the DSM is coming from a source, but I've seen the number reported differently, and I think it depends on what you're counting as individual diagnoses or subdiagnoses or things, and so it's a little bit complicated, but it's a ballpark number, I guess. Second, I will be including the DSM's take on a couple disorders as we go through so you can kind of get an idea of how things have changed over time. So the disorders that we'll be tracking are autism, bipolar, and homosexuality. One of these things is not like the other. All of this started with the US Census. So in 1840, they added an item to the census to try to get a sense of how many people in the country were experiencing idiocy or insanity. Over the next 40 years, the process was refined some, and in the 1880 census, there were 7 mental health categories included in the census: mania, melancholia, monomania, paresis, dementia, dipsomania, and epilepsy. In 1917, the census adopted a plan that was written by the American Medico-Psychological Association and the National Commission of Mental Hygiene, and this plan was to get structured data from the mental hospitals that were in the US at the time. In reality, this basically just served to organize or classify the different types of information that was coming in from the hospitals. In 1921, the American Medico-Psychological Association rebranded into the American Psychiatric Association, or the APA, not to be confused with the American Psychological Association, also called the APA. In this video, we are talking exclusively about the Psychiatric APA. The APA teamed up with the New York Academy of Medicine to develop the American Medical Association's Standard Classified Nomenclature of Disease. Just rolls off the tongue, that one. This was sort of like a proto-DSM, and the goal of it was to help psychiatrists be able to standardize their diagnosing of people. Starting during World War II and continuing afterwards, the U.S. Army and Veterans Administration developed a classification system to try and encapsulate all of the psychological, physiological, and personality disorders that they were treating. At the same time, the World Health Organization's International Statistical Classification of Diseases and Related Health Problems, or ICD for short, thank God, 6th edition was published. This is included here because it included psychological disorders for the first time. The ICD-6 mental health stuff was apparently a bit of a failure because the countries in the UN didn't use it. They just continued using their own systems, and the US was just as guilty of that, and at the time had 4 different classification systems in use across the country. In 1952, the first edition of the DSM was published by the APA Committee on Nomenclature and Statistics. The first edition of the DSM was a variant on the mental health stuff in the ICD-6. We're currently on ICD-10, and we'll talk about that more later, but just now you know. The DSM had a focus on psychological disorders, as opposed to the ICD, which tries to just be everything. And the DSM was targeted towards psychiatrists working in basically inpatient hospital settings. There was apparently a then popular theoretical approach to how the psychological disorders were thought of and treated. This was the work of Adolf Meyer, who was the first psychiatrist-in-chief at Johns Hopkins Hospital. He took biological, social, and psychological factors into consideration when treating people. If you saw the psych disorder video, this probably sounds like the biopsychosocial approach that we talked about there. But it's pretty distinct from what I can gather. So the taking in the different factors is similar, but Meyer's approach argued that psychological disorders were a consequence of personality problems. Nothing to do with the brain. Nope, it's all just personality, so if you can fix the person's personality, you can fix the disorder. Given Meyer's framework, I think you can probably imagine the emphasis of the DSM at the time. Something I learned in pulling together this video is that the theoretical approach sort of underlying psychiatry at the time was largely psychoanalytic or psychodynamic. The first DSM had 128 categories or classifications of disorders, and they were organized hierarchically. And this hierarchy reflected the way that most practitioners would go about diagnosing a patient. Is it some form of legitimate brain issue like a metal rod through the head? Or is it functional in nature, meaning personality-based? And the functional disorders were further categorized as either psychotic, neurotic, or character-based. One critique of this first edition was that the descriptions didn't really clarify what the disorder was beyond what you could really figure out from the name of the disorder itself. Not surprisingly, this didn't really help the practitioners be consistent in their diagnoses. I'll include here how the DSM is written, although it's certainly applicable from the first edition up through 5 and probably past that. So the DSM is written by committee. The first edition just had one committee working on stuff, and the 5th edition had many committees working on all the different parts of the DSM. And so these committees are supposed to talk to the clinicians, talk to the experts on the different disorders, pull together the research, and just take all of this information to try to distill out what the essential features of a disorder are, what the different disorders are, how they relate, all of that information. Part of this review and revision process is to incorporate new information that we have that might change how we think about a disorder. You'll certainly see this with autism and bipolar, as well as homosexuality. Checking in with our track disorders over time, autism hadn't been identified yet, so not surprisingly, it's not in the DSM. Bipolar, then known as manic depression, was classified as a psychotic disorder in the first edition. And some elements were similar, so there was mania, which are the heightened states, there was the depressed states, but there was a big emphasis on the psychotic elements, so hallucinations or illusions, delusions that a person might experience. And we still have psychotic elements in the diagnostic criteria for bipolar, but it's a subset. Like, it's not all people with bipolar have this. It's a subset with psychotic features. So there is a definite change in that over time. A same-sex attraction was put in the sexual deviation class. And one popular school of thought at that point for how somebody develops this disorder is that the person didn't properly resolve their Oedipal complex. Guess what school of thought that was? Given the poor adaptation of the ICD-6, a British psychologist, Stengel, was asked to figure out what was going on. He analyzed the classification systems used around the world and found that each country had at least one independent system, if not more. Stengel was appalled at the lack of consistency between systems and so called for a unification of the systems. As a consequence of this, the WHO organized a bunch of committee meetings to try to develop something that would be usable by all these different countries. The ICD-8 was written in 1965 and incorporated these changes. The DSM-II was pretty similar to the ICD-8 and came out around the same time. One difference between the two was that the ICD-8 only had a list of the approved disorders and terms, whereas the DSM-II had those disorders and terms, but they also had brief definitions so that practitioners could try to figure out what they were besides just using the name. The DSM-II grew to 193 diagnostic categories, but still had the same hierarchical organization as the first edition. Part of this growth in the number of classifications is an incorporation of outpatient issues. So depression, anxiety, things that could be treated on an outpatient basis and didn't necessarily require being held in the psych ward. In addition to the second edition was a miscellaneous diagnosis for people who sort of fit in a family of diagnoses but didn't really meet any particular one. Today, this is known as not otherwise specified, so it might be like depression, not otherwise specified, if they meet some of the criteria but not really all of them, but they are depressed. Checking back in with the disorders that we're tracking over time, autism was first described in 1943 by Leo Kanner. It was first included in the DSM-II as a form of early onset schizophrenia with marked detachment from reality. The diagnostic criteria for autism in this second edition was pretty open-ended, so it was really kind of at the psychiatrist's discretion if they wanted to diagnose somebody with it or not. Bipolar was moved from being a psychotic disorder to an affective disorder, so affect being sort of mood. There was still mania and depression included in the description, but now you would be classed as either a mania type, depressed type, or a circular type. And if we compare those categories to our current classification system, if somebody was a manic type, They would basically be classed today as having unipolar mania. A person with the depressed type would be classed as unipolar depression, and only really the circular type would reflect our current definition of bipolar. Same-sex attraction or orientation was still a sexual deviation in the DSM-II up until the 7th printing of it, when it was moved to the sexual orientation disturbance category. Some say that this is when homosexuality was removed from the DSM, although the lingering presence in the disturbance category kind of suggests otherwise to me. This shift required a lot of activists making a lot of noise, in addition to the research done by people like Kinsey or Hooker, who found that same-sex consensual sex experiences weren't exceptionally rare, coerced, or occurring in exclusively disturbed people. I'll bring in some popular media here. One character in One Flew Over the Cuckoo's Nest and one from Girl Interrupted, at least the movie version, were in the psych ward because of their sexual orientation. This wasn't fiction exaggerating. Up until fairly recently, if somebody was caught or accused of being gay, they could face jail time, they could have a general hold in the psych ward, or while they're there, they could be forced to go through aversion therapy. As a side note, because of where we are in the flow of time, we will talk about the anti-psychiatry movement and the deinstitutionalization movement that happened around this time in the psychiatry video. But suffice it to say that the 1960s and 70s were a huge period of change, the treatment of psychological disorders being no exception. One Flew Over the Cuckoo's Nest, written by Ken Kesey, was published in 1962 and really helped sort of spark awareness of what life was like inside the psych ward. The movie, starring Jack Nicholson, was released in 1975, so kind of at the tail end of things, but still impactful. The 1950s and 60s also saw the advent of a lot of psychiatric drugs come into being. And so for things like schizophrenia, this was a game changer. It wasn't sort of a life sentence for a person once they developed schizophrenia that they'd have to spend the rest of their life in the psych ward. If they responded to the medication, they could be released. This was huge. In 1973, Rosenhan's On Being Sane in Insane Places was published in Science, which, if you don't know sort of journals in their tiers, it's a top-tier journal. It was a controversial paper, to say the least. We talked about it in the psych disorder video, but briefly, Rosenhan and several colleagues got themselves checked into different psych wards across the US by saying that they were hearing a voice say empty, hollow, and thud over and over again. Once they were admitted, and all of them were, they stopped hearing that voice, they were to take notes on their experience, and they were to try to get out. The stays tended to average about 2 weeks, with the range going from 7 days to 52 days inside the psych ward. And it was reported in the paper that a lot of the other patients could recognize the experimenters, like, why are you here? You don't belong here. What are you doing here? Knew they were up to something. But all of the hospital staff apparently didn't. They treated these people like they had schizophrenia, or in one case, I think bipolar, as the diagnosis. Worryingly, the paper includes descriptions of the patients being treated not quite human by the staff. Interactions between the staff and the patients would be very remote and distant and not engaged, so eye contact wouldn't be made, chit-chat wouldn't happen, like it was just giving them their meds, checking in on them, nothing else. Assumptions would be made about why patients were behaving the way they were instead of asking them why they were doing something. The example in the paper was, I think Rosenhan himself hearing a psychiatrist with some students walking through and like, yes, see how the patients wait outside the cafeteria for an hour before lunch is served? This is because they have an oral fixation that's driving the blah, 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 blah. You know, it's not that the psych ward itself is boring and there's nothing to do and lunch is one of the only things to look forward to. No, it's an oral fixation that's causing this. The most striking example is A nurse, a female nurse, going to where the male patients were, one of the day rooms, undoing her top, adjusting herself in her bra, redoing her top back up, and going back to where the rest of the staff were. Kind of like how you would change in front of a dog without a second thought. Many fired back at Rosenhan's methodology and also his claim that the psych hospitals weren't doing a good job distinguishing the sane from the insane. One of those people who fired back was Robert Spitzer. Spitzer was highly critical of the experiment, the methodology, the findings, the implications, and this wouldn't really be worthy of note except for the fact that Spitzer was the lead editor behind the DSM-III. But around the same time, other research papers were coming out indicating that, at least in the US, psychiatrists were still doing a really bad job at consistently diagnosing people. The DSM-III was published in 1980, and work on it was coordinated with work on the ICD-9, the next iteration of that. The DSM received a massive overhaul for this edition. There were more thorough descriptions for the different diagnostic categories, including how to differentiate one disorder from other similar disorders, and what was known about the onset and typical course for the disorder. A multi-axial diagnostic assessment system was added that tried to incorporate more than just the disorder itself in a person's diagnosis. The DSM-III included 228 separate diagnoses, and the hierarchical organization of the previous editions was dropped in favor of organizing the different disorders into families based on symptom similarities or proposed causes. This massive change was reflective of a huge change that happened in psychiatry. The leads behind the DSM-III wanted to get psychiatry back to more of a medical basis instead of being founded on psychoanalytic or psychodynamic approaches. In response to the anti-psychiatry movement and its claim that people who weren't wanted in society were the ones who were being classified as insane, the DSM-III includes a tentative definition for what constitutes a psychological disorder. Each of the mental disorders is conceptualized as a clinically significant behavioral or psychological syndrome or pattern that occurs in an individual and that is typically associated with either a painful symptom, distress, or impairment in one or more important areas of functioning, disability. In addition, there is an inference that there is a behavioral, psychological, or biological dysfunction and that the disturbance is not only in the relationship between the individual and the society. Going back to the disorders we are tracking over time. So in between the DSM-II and the DSM-III, this idea for autism, or the cause of autism, came about that it was due to refrigerator mothers. So the idea was that autism in the child was caused because the mother was too cold and too unloving and not nurturing and receptive and loving, and it was all her fault. Fortunately, by the time the DSM-III was written, this idea was mostly discarded when enough evidence had accumulated that autism does seem to have biological roots. The DSM-III separated autism from schizophrenia and categorized it as a pervasive developmental disorder, or PDD. The three essential features of autism in the DSM-III were a lack of interest in people, severe impairments in communication, and bizarre responses to the environment, all developing in the first 30 months of life. Manic depression was renamed as bipolar depression and separated out as a separate diagnosis from unipolar depression. The language changed so that a person would experience manic, depressive, or even mixed state episodes instead of being predominantly one of those types. The hypomania was added as a form of mania that people could experience, where it's not quite as severe as full-blown mania, but it's still a heightened state that people can end up in. And if a person experienced hallucinations or illusions, they would receive the with psychotic features specifier. Same-sex attraction was moved again from the sexual orientation disturbance to an ego-dystonic homosexuality classification. The proliferation of structured interviews, apparent inconsistencies within the DSM-III diagnostic criteria, clinicians' continuing preference to not use criteria but matching people to what a person with a given disorder should look like, and a shift in thought for how the classification structure should be, led to the DSM-III revision, or DSM-III-R, being published in 1987. This edition contained 253 diagnoses, with a not insubstantial part of that growth coming from a full inclusion of the sleep disorders. Apparently, the sleep disorder committees couldn't get their stuff in on time for the publication of the third edition, so it was included in the revision. The DSM-III-R also included an appendix of proposed diagnostic categories needing further study. In this edition, the 3 diagnoses that fit into this category were late luteal phase dysphoric disorder, basically PMS, sadistic personality disorder, and self-defeating personality disorder. Checking back in with our track disorders over time, autism received a huge rework. So there was a milder form acknowledged and included that was called pervasive developmental disorder, not otherwise specified, and it was kind of more like a high-functioning autism than had previously been incorporated in the DSM-III, and the requirement that this happen before 30 months of age was dropped. Bipolar disorder didn't receive any changes in this edition, but the ego-dystonic homosexuality was dropped, just gone. And for the most part, same-sex attraction was out of the DSM finally. But there was still sexual disorder not otherwise specified for people who experience distress as a result of their same-sex attraction. In 1994, the DSM-IV was published. This edition tried to have an incredibly thorough review of available literature to support existing disorders as they were or argue to change them, incorporate new diagnoses, and rearrange disorders and families as deemed appropriate. The DSM-IV included 383 diagnostic classifications, and the appendix of those warranting further study grew to 17. Once again, the 3 disorders that we're tracking over time. Autism was first categorized as a spectrum disorder in this edition. Specific diagnoses were also added, including Asperger's disorder and child disintegrative disorder, or CDD, in which a child that had been making seemingly normal developmental progress suddenly regresses in ability. The different discrete disorders were included here in autism because it was predicted that these different disorders would have distinct genetic causes behind them. The changes to bipolar were minor. So there was a change to a mixed episode so that a person had to be manic and depressed at the same time for at least a week for a mixed episode to occur, and hypomania was recognized to occur episodically. There was some refinement in language so that there is an explicit distinction between bipolar type 1 and type 2. And the key difference between the two types is that in type 1, the person has experienced at least one manic episode, and type 2, they've experienced at least one hypomanic episode. The text revision to the 4th edition was released in 2000 and was mostly minor changes. So descriptions were changed a little bit for some of the disorders, and some diagnostic criteria were cleared up. The DSM-V was published in 2013 and saw another huge overhaul of the entire thing. The axes were dropped entirely, and the disorders were categorized into different classes based on similarity. And the similarity can be based on just the symptoms, but it's tending to be more reflective of the current working hypotheses for the underlying brain regions or genetic causes. The reworking of categories and trying to not rely on not otherwise specified for everything resulted in the growth of the number of diagnoses to 541. The DSM-V also has tried to incorporate dimensions instead of just discrete categories for some of the disorders, like autism. And so shifting to a dimension allows for a finer level of detail when talking about the severity of somebody's disorder or when talking about the prognosis or outcomes. Final check-in with our disorders that we're keeping track of over time. Autism received another huge rework. The predicted autism genes didn't pan out to be as clear as they'd anticipated. There are genes that can increase the likelihood of somebody developing autism, but those genes number in the hundreds. Gone are Asperger's syndrome, pervasive developmental disorder not otherwise specified, and other classical autism diagnoses. Now there is autism spectrum disorder with 2 key features: persistent impairment in reciprocal social communication and social interaction, and restricted repetitive patterns of behavior, with both being present in early childhood. And it seems that this rework has excluded some of the people who had previously been on the higher end of functioning in the autism spectrum. Bipolar was reclassified as a separate class instead of being part of the mood disorders, and some overspecificity was removed so that previously it would be bipolar type 1, most recent episode manic. Bipolar type 1, most recent episode depressed, blah, 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 blah. Now it's just a specifier instead of having discrete diagnoses for that. One consistent critique of the DSM over time has been that it can medicalize normal behaviors. In theory, if the diagnostic criteria were 100% crystal clear, this might not be an issue. However, there is a bit of a requirement for the mental health practitioner to make a judgment call on what the person is experiencing and how severe their experience of that is. As an example, for a while, grief and bereavement have kind of been in with the mood disorders as a form of depression if a person is taking a certain period of time to mourn the loss of someone, or if their mourning is more intense than average. And are we really talking about a form of depression that kicks off as a result of somebody dying in that person's life? Or is this more reflective on what we view as acceptable and normal in society for grief, and this person is going beyond that? Not necessarily meaning that there's something going on with their brain chemistry. Related to medicalizing normal behaviors, the DSM-V saw a shift in basically lowering the threshold for what is abnormal behavior, thus making more average behaviors kind of on the threshold of abnormal. Another huge issue is the huge overhauls that can happen between editions. When this happens, practitioners essentially have to relearn the DSM in order to continue to use it to make diagnoses. Another criticism is that the DSM is primarily centered around a white Western norm, and so this is excluding many other cultural and societal norms, but it hasn't really been addressed yet. A complaint that has become more and more problematic over time is this issue of transparency for who's putting together the DSM and how. The people involved in the committees behind the DSM-V had to sign non-disclosure agreements for the first time, and this raised a lot of eyebrows in the community. Spitzer, the guy you might remember who had beef with Rosenhan about that experiment, and who was the lead editor on the DSM-III, publicly threw a little bit of a shit fit about this because he was saying that this NDA would make it impossible for people on the committees to talk to the researchers and the experts out in the field to get their input on things. More worryingly, the percentage of people who were working on the DSM-V that had ties to the pharmaceutical industry was up to 70%. For comparison purposes, on the DSM-IV revision, it was 14%. To make it that little extra bit worse, it's not that people with these ties are equally distributed across all of the different committees. In the fourth revision, at least, all of the people who are working on the mood disorders and the schizophrenic and other psychotic disorders had ties to the pharmacy. And this is concerning because those are ones that we definitely treat with drugs most of the time. Needless to say, there are concerns about conflicts of interest running amok here. And this is reflected by a shift from the biopsychosocial approach to one that's basically biological. And having this biological approach means that we're more likely to just use medication instead of addressing the psychological or social things that might be going on. More recently, a criticism has developed about the validity of the diagnoses in the DSM. Basically, what this means is people are starting to question if these diagnoses are accurately reflecting the psychological disorders that we think they are. The former director for the National Institute for Mental Health issued a statement in 2015 that the NIMH wouldn't fund research that solely relied on the DSM for diagnostic criteria. His argument was that the DSM relies on clumping the symptoms as opposed to taking a broader perspective that includes genetics, brain imaging, and cognitive aspects in addition to the symptoms. The DSM, then, isn't the best foundation for treatment. This validity issue is related to another criticism that the DSM, by focusing on the symptoms and not the underlying causes, is basically missing the forest for the trees. Okay, so the DSM has some problems. What are the alternatives? The ICD has come up previously, so let's start there. The International Statistical Classification of Diseases and Related Health Problems, ICD, is the medical classification system by the World Health Organization. It classifies all medical diagnoses, so that includes mental health as well as general health. The ICD is currently on version 10, but version 11 should go into effect in 2022. The development of the ICD-11, in contrast to the DSM-V, has been more of an open source project. Anybody can contribute as long as they make a proposal that's empirically based. And another aspect of this is that the researchers and practitioners who aren't directly involved in the writing of this document can see the state of the document, see the draft of it, and give their input. The ICD-11 will have a description for each entry in it, so the DSM will lose its edge over the ICD there. There's an international advisory group who is helping with the revision process on the psych disorders, basically, and it's hoped that this will help provide more cross-cultural validity in the diagnoses. But given the strong connection between the ICD and the DSM in the past, there are concerns that the ICD-11 will have a similar issue that the DSM-V has, in that it's focusing on the symptoms and the problems and not necessarily on the root causes for those different disorders. There's another alternative that, in my opinion, is probably the most promising, but in a long-term sense. Right now, it's not usable. The National Institute of Mental Health's Research Domain Criteria, or RDoC, is trying to build a new classification system that's based on overt behaviors, genetics, clinical studies, and neuroscience. The assumptions of the RDoC, as outlined by the former director for the National Institute of Mental Health, are: a diagnosis approach based on the biology as well as the symptoms must not be constrained by the current DSM categories. Mental disorders are biological disorders involving brain circuits that implicate specific domains of cognition, emotion, or behavior. Each level of analysis needs to be understood across a dimension of function, and mapping the cognitive, circuit, and genetic aspects of mental disorders will yield new and better targets for treatment. At this point, the RDoC is a research framework, so it's providing guidance for where current and future research should go. Saying this in a different way, the RDoC is sort of like a paper outline with holes and placeholders everywhere. And so you know where these holes and placeholders are, so you can do research to answer the questions and fill in those holes. The RDoC wants to capture the full range of human experience, normal to abnormal, ordered to disordered, so that we have an understanding of sort of the continuum of this instead of just saying some threshold, this is normal, this is not normal. Related to this last point, the RDoC categories will be determined based on what falls out of the data. And so this is important because we've had hints, very strong hints for some time, that the different disorders aren't necessarily nice and clean like we say they are in the DSM. There are very strong hints that there are subtypes or variants for these different disorders because of how people respond to treatment, and it's not uniformly. Some people for depression will respond to the selective serotonin reuptake inhibitors, or SSRIs, like Prozac. It'll work for them. Other people, that won't work. They might respond to the atypical antidepressants, like Wellbutrin. Some people, drugs won't work at all, and we have to go with other treatments like ECT or electroconvulsive therapy, ketamine infusions, other drug treatments to try to get them help. And the fact that not everybody responds the same to treatment kind of suggests that there's something different going on in these different people, and this could be indicative of different types of depression. A YouTuber, who will not be named because the handful of interactions I had with him were more than enough, seems to think that because the SSRIs are not a silver bullet for depression, that means that the serotonin theory for depression is wrong. Therefore, depression is not a valid psychological disorder, and all psychological disorders aren't real. However, this differential response to the SSRIs for depression under RDoC suggests that we don't fully understand depression yet. It works for some people, so maybe the serotonin hypothesis of depression is true for that type. But we need to investigate a lot of people with depression of the differing types or parent types. We need to look at what's going on in their genes. We need to look at what's going on in their brains. We need to understand the full system. And if we can fully understand what's going on at the genetic, the neurocognitive, like every level, then we should be able to effectively treat people better. But this is the huge downside of RDoC. Doing this research for all of the disorders is going to take a lot of time, a lot of labor, and a lot of money. So, like I said, I think this one is the most promising, but it is a long way out from being something cohesive that we can use to treat everybody. A couple more alternatives briefly. One is an approach rooted in positive psychology that focuses not on people's weaknesses, as is the case with the DSM and the symptoms, but to focus on their strengths and try to help them that way. An approach built on psychodynamic theory, something relying on personality dimensions that break down all of the psychological disorders into 6 spectra dimensions that somehow provides practitioners more info. The power threat meaning framework. This rejects psychiatry and diagnoses that are based on the individual man. It's the man that's the cause of what society labels as disorders, man. So, that's the DSM. We're on version 5. It's got some problems, but new contenders to the throne haven't been able to usurp it so far. The DSM-V is ubiquitous in the mental health practitioner community, although the ICD-10 and probably 11 will gain traction on that. The DSM has come a long way, with many missteps along the way, some more damaging than others. There will probably continue to be missteps as we move forward, but exactly what those missteps are can be hard to predict. I think that the RDoC is the best replacement option long-term, but it's going to take a lot of time and money to get there. Okay, DSM? Check. The next non-Peterson video to finish off the Patreon poll winner will be Psychiatry, so you can expect that in the nearish future. As always, like if you found this video educational, leave a comment with questions or thoughts you have on this stuff. You can hit me up on Twitter, check out Discord, support the channel on Patreon, blah, blah, blah. See you in the next video. Bye!